So I'm delighted to introduce Dr. Jamie Adams. She is an associate professor of neurology and a movement disorder specialist at the University of Rochester and the associate director at CHET, the Center for Health and Emerging Therapeutics.
All right. Hey, everybody. It's so nice to be here and see a lot of familiar faces. Thank you for that introduction, Ruth. So I am here on behalf of the Center for Health and Technology, giving this talk on behalf of that group. I wear a number of hats at the University of Rochester, as Ruth mentioned, so also a movement disorder specialist and interim chief of our division. But today I'm going to be really focusing on the work that I do with CHET and the Center for Health and Technology. This group has a number of different divisions and offerings, including a drug packaging group, an outcomes group, an analytics group. But today I'm really going to be focusing on our innovations unit and some of the research that we're doing as part of that division, some of the technology and prevention work for Parkinson's disease that we do. Dr. Chad Heatwall is a neuromuscular specialist at the University of Rochester, and he is the director of CHET. He does a lot of work in outcomes measure development and has developed dozens of clinical outcomes measurements for a variety of diseases, including one for Parkinson's disease. I'm not going to be talking too much about those, but I just want folks to know that we're doing a really quite a bit of work in Parkinson's disease and have done so for decades. So we'll start by just sort of introducing the Center for Health and Technology. So what is this group? This is an academic research organization. What does that mean? So a clinical research organization is a group that runs and manages clinical trials. And so we do this through the University of Rochester. So it's considered an academic research organization. It's pretty unique. There's not a lot of universities that have such a group, and it's really special in that this really started as a group for movement disorders and neurology, and so we've run quite a few clinical trials for Parkinson's disease and for neurologic disease. We have also been on the forefront of telemedicine and using virtual visits in our clinical trials, as well as incorporating new tools and technologies into our trials, which I'll talk about. So things like smartphone applications and wearables as more objective measures of Parkinson's disease and other diseases. The mission of CHET is to advance human therapeutics, health, and knowledge through exceptional people, skillful research, and partnership. I think that's really paramount to what we do in all of our work. We have, and I'll get to this a little bit in the next slide, we've run over 150 clinical trials, included over 45,000 research participants over the decades that we've been doing this. And these have led to 12 FDA approvals. So really a special group, and I'm really proud to be a part of CHET and represent them today. So as mentioned, over 150 clinical trials, 75 of which have focused on Parkinson's disease, so really a specific focus of CHET. Some of the studies I'll talk about in a little bit are more of our sort of device and virtual visit studies, including Light PD, At-Home PD, and Watch PD. As I mentioned, CHET has been led clinical trials that have led to FDA-approved treatments, including 5 for Parkinson's disease. So those drugs were pramipexole, entacapone, selegiline, razagiline, and retigatone, which is the Nupro patch. So again, like some really cool work that we've done. We've been doing this for decades. As mentioned, we've also been pioneering tools and technologies in Parkinson's disease. Virtual visits or video conferencing to conduct remote assessments really eliminates any sort of geographic barriers, and we're using this strategy and this way of conducting trials in many of our studies, and I'll talk about some of those. The ones over here that are pictured that are using this strategy are Watch PD, At-Home PD, and Valor PD, all pretty, again, unique experience that we have in conducting trials that use virtual visits to do our assessments. And then new tools like smartphone applications and wearable sensors can be incorporated into clinical trials. They can enable objective and frequent assessments in real-world settings. So traditionally, our trials, our outcome assessments would have people come in at episodic, every 4 to 6 weeks. We'd have them tap their fingers and we'd give them a score. And so now we're really looking at things like wearables and other tools to make that a little bit more of a frequent assessment and more of an objective assessment. Because you can imagine if you're feeling really good on the day you come into your trial, your score on that test might be different than if you had a poor night's sleep or not having a particularly good day. So trying to really come up with some more objective assessments for our trials to hopefully get some more drugs approved for this disease. I guess I'll move on to... So this is, again, focusing on our innovation unit at the Center for Health and Technology. We've been doing this work for over a decade, looking at a variety of different tools in Parkinson's disease. We were one of the first groups to start using telemedicine. Before that was, approved by insurance companies to be a way for us to care for folks with Parkinson's disease. Dr. Dorsey had gotten a grant that allowed us to do these visits for free for people with Parkinson's. So we've really been doing sort of virtual visits and technology research for quite a while. This is just a timeline of some of the studies that we've done using a variety of different tools. This started off with an Apple smartphone application called Empower, which was part of their research kit. That was done in 2015. We've continued on to use a variety of sensors. Some are adhesive accelerometers that many of you may have participated in some of these early studies. We're now using radio wave sensors to track people's movement, and some of the more recent tools we're using are wrist-worn wearables and some advanced smartphone applications. Most of these studies you can see here are in Parkinson's disease and Huntington's disease, but we've also done some trials in dermatologic disease like atopic dermatitis, looking at scratch, trying to objectify scratch using a wearable. And then recently, something I'm pretty proud of is that we got an FDA grant to do a digital measures study in Huntington's disease. So really excited about that. So I'm going to talk about a few of the studies that we're doing. Not all of them are currently enrolling, but some of the ones that the Innovations Unit has been leading for quite a while and I think are really exciting. So WatchPD was the first multi-site digital measure study in early untreated Parkinson's disease. This study started in 2019. It was done at 17 sites across the United States. It was originally designed to be a one-year study, and it was using a variety of different digital measures. So one of which was the Apple Watch, which has many sensors that can detect tremor, gait, balance, and so using that for sort of passive monitoring at home. It also used a smartphone application called Brain Baseline, which was developed by a company called Clinical Inc. This provides a convenient way to track and report Parkinson's symptoms, including motor and non-motor symptoms. And then we use these research-grade APM Opal sensors in clinic. So this study initially in the first year was an in-person and remote study. So we did some visits in person and then did some at home. That study resulted in some really great data, I think, early on when we were using these tools that showed that the tools could differentiate between people with early untreated Parkinson's and healthy controls. And then we've also seen some change in some of the measures over that first year. So that study ended, and we kind of got some feedback like, oh, we should really be following this cohort for longer. A year is not really long enough to be monitoring people with early Parkinson's. Their symptoms might not change a whole lot in that first year. So we re-recruited back into a study called WatchPD2, which is funded by the Michael J. Fox Foundation. And this study is a decentralized remote study where we're doing all of the visits over video. So continue to include people from the other sites across the U.S., but instead of them going to their sites, they're seeing me or one of my colleagues over a video to do their assessments. And this study just uses the Apple Watch and the smartphone application. And what we've seen is that over the first 3 years of the study is that things like gait speed, arm swing are really deteriorating based on the Apple Watch and the smartphone. So maybe something that we could measure in an objective way in clinical trials in early Parkinson's disease. Another unique thing about this study, besides sort of the length of time we've been monitoring people, is that early on we got feedback from FDA that we really needed to be making sure that what we're measuring with these tools mattered to people. And so we included a qualitative interview study that uses this symptom mapping technique that was developed by a researcher at the University of Massachusetts, Jennifer Mammon, and she's been working on this project with me for 5 years now. We've done 4 years of interviews in these folks, looking at both how are bothersome symptoms and impacts of disease changing over time, and how are our tasks that we're measuring and tools, our measurements that we're measuring with the digital tools relevant to people, and how is that changing over the first years of their disease. So I'll move on to at-home PD2, which Dr. Schneider should probably be up here talking about since this is her study, so she's the principal investigator of this study. This second version of the study is funded by an R01 grant from the NIH. This study is extremely exciting and very unique. It includes participants from a variety of clinical trials that we've followed longitudinally after those trials have ended in a remote fashion. So again, a siteless virtual visit study where we're doing visits remotely. People are doing online surveys, and they're also doing a variety of digital measurements and tasks. So there's a smartphone application, and then in this extension study, they're also using 2 wrist-worn devices to get some measures of activity and gait and see if we can predict things like falls or cognitive decline in people with Parkinson's disease as we monitor them over time. So the 2 devices that are being used in this newer version of the study are something called an actigraph and then a Fitbit, which is a consumer device that is available, and doing some comparisons between those 2 devices. If you want more information, here's where you can go for this study. And then finally, Light PD, which we do have this device at the Chet table. So welcome anybody here to go look. It's table 18. Chet is staffing. People will be here all day and have some of these tools that you can try on, including some of the watches and also the light therapy device. So at this conference last year, I spoke about Light PD. So this is a phototherapy study. It is the first remote study looking at a device in Parkinson's disease. We're looking to recruit 300 people. I think we're just over 200, so really trying to get that last 100 folks. So if you are interested, I encourage you to go to this website. It is looking at, again, a phototherapy device that emits light, either in the therapeutic wavelength or in a placebo wavelength. And in early studies, this device showed some benefits for both non-motor and maybe some motor symptoms in improving quality of life for people with Parkinson's disease. You have to have been on Parkinson's therapy for a year, and you have to be on a stable regimen with no plans to change it over the 6 months of the study. But other than that, the inclusion-exclusion criteria are pretty flexible. And I think this is exciting. It's sort of a non-interventional, non-drug way of perhaps supplementing or amplifying your therapies for Parkinson's. And again, that is a 6-month study. There's a series of 4 or 5 visits, all conducted over video. You don't have to come into clinic for it. We also have a research registry that helps us recruit people into our trials. So if you're interested in participating in research, please sign up for this. It really helps us identify people that are interested in participating in research. And even if you might not qualify for all the studies are doing, it gives us a sense of who might be interested. Even if you don't have Parkinson's disease, but you would be willing to be a healthy control, you can sign up for this research registry, and here are the steps. I think this will be available to folks after this talk. And then finally, many of you know Dr. Ray Dorsey. He is my mentor and colleague. He has shifted a lot of his research and his energy into prevention of Parkinson's disease. So as we know, there are a number of environmental factors that can put you at increased risk for Parkinson's, and Ray has really been on the forefront and really spearheading advocacy and policy changes to try to eliminate some of these chemicals. So has done quite a number of on-site investigations of a variety of chemicals highlighting risks of chemicals. And then Chet has produced a good amount of educational content highlighting Ray's work. And then at the table, there is, I think there's going to be a raffle for maybe his first book called Ending Parkinson's Disease. Many of you may have copies of this book. We also put out a video called The Long Road to Hope, sort of based on the book and based on a dozen people with Parkinson's disease experience. And then finally, Ray has written a new book called The Parkinson's Plan, and this will be out in August. Again, kind of outlining some actionable steps to prevent and slow and treat Parkinson's disease. So with that, I don't know how I am on time, but we'll end there. I'm happy to take any questions. I'll also be here for a few minutes after at the Chet table, which again is table 18, and would be happy to chat with anybody.
Thank you, Dr. Adams. So we do have time for a few questions. We do not have a microphone, so please speak up, or I can come help shout for you if you need to.
Hi. Regarding early detection, I've been reading a lot about some research about online typing tests. I know Parkinson'sResearch.org has a free online typing test. Is that something that you guys are also?
Yeah, we haven't.
Repeat the question, please.
Yep, so she's asking about, there's a couple of different detection of Parkinson's disease tools that are being developed. One is a typing test. I'm aware of these tools. We don't use them in any of our studies. We have done and are using a video analytics tool that looks at changes in facial expression and tapping and some other measures that we're looking at as a sort of detection tool in Parkinson's. Much of my research is more looking at tools that detect progression of disease. But I think I'm not, without knowing the exact one you're talking about, but I do know they exist, but not in any of my studies. Yeah.
How much research are you doing that the federal government is funding and
Yeah, so question about how much government federally funded studies are we doing and if we had any impacts so far with the change in administration. We do a fair amount of NIH or FDA or federally funded studies. Both Dr. Schneider and I have grants, neither of which, as far as I know, have been affected. I think there's some uncertainty and certainly some anxiety around this, but so far, so good. I don't know if you have anything to add there.
Oh, thank you for the question. That is a really important topic. I imagine most people in this room are aware of what's happening with all the cuts at the federal level, but the NIH is really being gutted. So just to name a few things that they've done is kind of targeted action against specific universities like Columbia University for one. They're cutting funding of programs that involve things that are related to DEI. So if you're interested in serving underserved communities, or if you want to help train people from underrepresented backgrounds, those grants are very much at risk. The other big thing that you may have heard about is the cut in the indirect rate. I don't know, does everybody in this room know what an indirect rate is? This was a really hard concept for me to understand as a young investigator, but they're really foundational to making universities run. So what an indirect rate is, it supports all of the services and the structure that is needed for research to happen at an institution like University of Rochester. So cutting that rate has implications in the tens of millions of dollars annually. So I don't mean to go, I've already gone on my soapbox, so I'm going to stop there. But NIH funding is really important to advancing science and developing new treatments for Parkinson's disease and other conditions in the U.S. and more broadly. So if I leave you with nothing else today, that's my message. Any other questions? I have one for Dr. Adams. Is there any way that folks in this room can get involved with research at Chet, or new studies that are in the pipeline that they should be looking forward to?
Yeah, so I think the light PD therapy is one that we're currently enrolling for, and then again signing up for that brain registry that helps us know that you're interested in research. And There are a couple studies that I think will be started that are going to be managed by Chet, and hopefully University of Rochester will be a site for some of those drug studies. Our division has a couple of studies upcoming in Parkinson's disease, looking at some therapeutics and also a skin biopsy test. So I'm happy to chat with people about more of that at the table. But yeah, lots of exciting things coming down the road, I think, for Parkinson's and for us as a site. So.
Thank you, Dr. Adams.
Yeah.
Thank you so much for coming back for our second presentation. I'm very excited to introduce Katherine Kavanaugh. She is a rep with Supernus Pharmaceuticals, and she's going to tell us today about a very new to the market therapy called ONAPGO. So thank you, Katherine.
Thank you. Hi, everyone. My name is Katherine, and I'm with Supernus Pharmaceuticals. I'm so grateful to be here with you today. It's such an exciting time in the world of Parkinson's care, and I'm thrilled to share something truly groundbreaking with you. Supernus is proud to offer GoCovery, the only medication approved to treat both off-time and dyskinesia. But instead of me telling you about that, I'm lucky to be joined today by someone who can speak from personal experience, Michelle, who is one of our GoCovery ambassadors. She is at our booth outside, and I would love for you guys to talk to her about it. If you or a loved one are dealing with dyskinesia, which are those involuntary dance-like movements, please take a moment to stop by our booth and talk with Michelle. Her perspective is much more meaningful than anything I could share because she has lived it. So today I will be focusing on something brand new, which is ONAPGO, the first and only continuous subcutaneous apomorphine infusion device. It's an exciting option for people experiencing motor fluctuations, and I'm looking forward to sharing how it may offer more consistent symptom control throughout the day. So ONAPGO was designed to help adults with Parkinson's disease experience more consistent control of their motor symptoms throughout the day. Now, as many of you know all too well, managing motor fluctuations can still be a challenge even when you're on levodopa or other therapies. Between disease progression, issues with digestion, and the up and down effect of oral medications, those disruptive off times can still happen daily. But what if there was another way? ONAPGO delivers a steady infusion throughout the day, up to 16 hours of continuous treatment. This means a significant reduction in daily off time and more get on time, those moments where you feel like yourself again. And here's what makes it really special. It's non-surgical, flexible, and it passes the digestive system altogether. No protein competition, no GI barriers, just consistent symptom control. In fact, doctors in Europe have been using this method for over 30 years to help thousands of people with Parkinson's regain control. So what does the research say? So ONAPGO was studied in both Europe and the US in patients who reflect what is seen in everyday clinical practice. On average, they were in their early 60s, but the full range was wide, from 32 to 83 years old. Most have been living with Parkinson's for about 10 years. 100% of the patients in the clinical trials were on levodopa, and the majority were on an adjunctive treatment, such as an MAOB or a COMT. Despite attempting to optimize oral PD medications, all patients still had 3 or more hours of off time at baseline. Now for the exciting part, let's look at the ONAPGO efficacy and safety data. So in the Toledo study, which was a phase 3 placebo-controlled trial in Europe, patients on ONAPGO saw a daily reduction of 2.6 hours of off time and gained nearly 3 hours of good on time, which is on time without troublesome dyskinesia. Those improvements started as early as week 1 and continued throughout the 12-week trial. So after the double-blind trial, we did the open label extension. So by 64 weeks, those numbers increased to 3.7 hours less off time per day and 3.3 hours of good on time per day. And at the end of the study, 79% of patients reported an overall improvement in their symptoms. Here in the US, we also ran the Infusion study, which was another phase 3 trial. Those results showed consistent improvements throughout 52 weeks with reductions in off time of more than 3 hours a day and over 3.5 hours more good on time. By the end of the study, 90 participants reported feeling better overall. That is 9 out of 10 patients. So ANAPGO has shown a very strong safety profile. The most common side effects were infusion site nodules, which are small bumps under the skin, but these rarely led to patients stopping the treatment. In fact, only 2% of patients discontinued due to infusion site nodule. Other side effects like hallucinations or dyskinesia occurred at similar rates to placebo or didn't lead to stopping treatment at all. And the US confirmatory safety profile remained consistent with Toledo. Now let's talk about the device itself. ANAPGO is compact, about the size and weight of a smartphone. I have it at my booth if you want to come look at the size and the weight of it. It's designed for convenience with multiple site placement options and pre-filled cartridges that aren't refrigerated. And you just on, snap, and go. So there's no syringe where you have to transfer the medication first. It's pre-filled cartridges, and we send you 30 a month, and you just use one per day to try to make it as easy as possible. Also, you're never in this alone. We offer a full circle of care program, which includes clinical nurse educators who are registered nurses that are with you every step of the way. From your first dose to daily use, they provide personalized in-home support for titration, education, and more. And these nurses can come whenever you need them. So they'll titrate you on the medication, they'll teach you how to use the pump, and they'll be there for you the entire time that you're on the medication. So to wrap up, ANAPGO offers something we haven't seen before, which is consistent control, continuous treatment, a legacy of clinical success, and a dedicated support system built around you. Thank you so much for being here today and allowing me to share this with you, and I hope this opens the door to new possibilities and better days ahead. Thank you.
Thank you, Catherine. Are there any questions? Go ahead.
Just quickly, so basically with ANAPGO, you still have to take a carbidopa levodopa, right?
So yes, so we start with ANAPGO. We start you off at a 1 milligram dose, and then our nurses titrate you to get you to the optimal dose. But by 2 milligrams, we start taking you off of your anti-PD medications. So at first, if you're on any dopamine agonists, we'll take you off of that first. Then the CompT or MAOB will take you off of next. And then last we would take you off was the carbidopa-levodopa, or at least reduce it. Yes, so so the question was, do you get the cartridges from your pharmacy? So yes, as soon as you tell your doctor that you're interested in it, they send a prescription form. We have a hub that takes care of all of like the prior auths or any appeals that come through, and then they ship it directly to your house. So it comes with 30 pre-filled cartridges and the device. And if anything happened with the device, there's a replacement kit that will be shipped right to your house.
Would that be the same with if you accidentally lost a cartridge or something?
So we send you 30 cartridges per month for each day. But if you lose a cartridge, I'm sure we could like somehow work that out. Yeah. Yes, so this is covered by Medicare, which is a huge step for us. I actually have some information at the booth about the steps to take if you have Medicare or commercial, and commercial can be as low as $0.
In the back.
Have you had patients in your trials that have had TBS that use your product? Or
Let me look in the studies.
So I don't know all of the trials, but I did happen to just read the Toledo article, and I believe Toledo excluded folks
Okay.
with DBS. But we'll let Catherine confirm that.
Yeah, so in the trials, the adjunctive therapies I'm seeing are dopamine agonists, COMT, MAOB, and amantadine.
Which are all different medications that, as physicians, we often use to help manage off time and reduce the amount of off time that somebody has. So this was just approved in the U.S. in what month, Catherine?
It was approved March 31st.
March 3rd. So this is brand new. So brand new that this is not really in the clinics quite yet. I think we're on the cusp of doing it. And, as a physician, we're very excited to have new options for treating and managing Parkinson's disease. And I think we will have to look to our colleagues in Europe. So as Catherine mentioned, the apomorphine infusion has been available since the early to mid-90s in different parts of Europe and other countries. So they have a wealth of experience. And so we'll look to them to learn about how to manage it, for example, in the setting of somebody who has CBS.
Thank you.
Yeah. Next question.
Skin irritation. So the most common adverse reaction was the infusion site nodule, but they were mild to moderate, and only 2% of patients discontinued because of them. There were no reports of infection, and we offer multiple placements for the cannula. So it's the stomach, the back if you have a caregiver, and then we give you a lanyard, and then the lower back and thighs. So there's multiple areas where you can use it, and you just want to rotate that to make sure you can try to avoid a nodule. So it is indicated for a 16-hour day on the device. So the nurses program the device for you, and then as they come to your home during the titration period, they up the dose as they see fit. So you can pause it to take a shower during the day, but you have to throw out the cartridge at the end of the day, and you don't sleep with it on. So it's indicated for a 16-hour waking day. And that also is what helps prevent any infections, because you're not wearing that cannula for so long on your skin.
So, Catherine, I know in Europe, it gets started sometimes in the hospital, sometimes in the outpatient setting. What is the rollout here in the U.S.? How's that looking?
So we do have a full clinical care team. On the prescription form, if the doctor wants to titrate you in office, that's an option. You can also choose if you want all home titration and our nurses to teach you how to use it. And then there's also a hybrid option, which means we can have our nurses come to the office the first time and kind of walk the doctor and the patient through the steps to get on the device. So really it's like up to you and your provider of how you want to go about it. So you can wear the cannula in the shower. Yes. Swimming, you would have to take the line out and then swim and then put the line back in, but the cannula stays, so you don't have to keep putting the cannula in.
Do you have one of the devices at your booth?
I have a device at the booth. If you guys want to check it out, I can walk you through it. And I think the easiest part is that it's completely pre-programmed by us. There's also a button if you are waking up in the morning slow or you're about to go to like rock steady boxing or some sort of activity, you can press a extra dose button 3 times a day. So it will give you like a little bit of a boost 3 times per day. You can use that.
And Catherine, I think many folks in this room are probably used to a little bit of a trial period, right? So it might take some time to find the right dose or the right settings. How long does it usually take with a NAPCO to get somebody on kind of a stable setting?
So, hold on 1 second. Sorry about that.
The question was how long it takes to find the right settings for you.
So we start the patient off at a continuous dosage of 1 milligram per hour, and then we titrate them up by 0.5 milligrams or 1 milligram per hour every 1 to 7 days until they reach the individualized optimal dosage of around 4 milligrams per hour of continuous dosage. So it could honestly take weeks to get you to that dose, depending on how slow or fast you want to start and how comfortable you are with the titration. But what we have seen so far with the prescriptions coming through is that providers are wanting to start them at the 0.5 titration instead of the 1, just to do it like as slowly as possible to get your body used to it. Yes. So he asked if I could be more specific on how it improved the patients that were in the clinical trials. So in the Europe study, which was a 52-week, it was a 12-week double-blind study, and then it continued into 52 weeks. Patients reported less off time of 3.7 hours a day and more good on time of 3.3 hours per day. So instead of a lot of the times, if you have less off time, it can mean that there's also dyskinesia replacing that off time. But with this, it's replaced by good on time, which is really important because that's that good on time, like your best self without any dyskinesia. So patients' daily off time in the clinical trials was cut in half from where they started.
So in other words, the study wasn't designed to look at specific symptoms, right? To say, is your tremor going to improve? Is your slowness of movement going to improve? It was designed to look at was off time, which you all know can look different from person to person. So for some people that's tremor, for some people that's slowness, for some people it's pain or cognitive symptoms. And that's where it showed a marked reduction in the number of hours per day where people felt off, and a corresponding improvement in the number of hours per day where they felt on without having too much of the extra wiggling.
Mm-hmm. And at the end of the day, at the end of the trial, patients experience good on time 75% of their waking day.
Okay, I saw another hand. Yes.
So that's a question for either your provider or our nurses. I'm not really sure how to incorporate the titration when a patient has had DBS, but the nurses that come to your home will definitely have a better answer than I do on that.
I assume it's probably safe to assume that this doesn't replace everything that someone might be on medication-wise, meaning you might be on some medication that you can wean off of, but there might be some working with your doctor that you still maintain to treat other symptoms.
Yes, this is, so instead of stopping all of your other medications. This is starting off as an add-on, and then as we titrate you up and we see your symptoms improving, we start slowly tapering you off of your other medication. So it's not like a complete change where we're taking you off your whole medication regimen and starting you on this. We start you on this, slowly work you up to the optimal dosage, and then start taking your medications down throughout that titration process.
Let me restate. So you just made it sound like this will replace all medications I'm on.
It can, but if you do need other medications like the carbidopa-levodopa, you can stay on that. So it really is up to our clinical nurse navigators to determine what you can start getting off of and what you should stay on with the device.
And this is strictly just for dyskinesia, you know, so what if you're not experiencing any downtime?
Yes, so this is indicated for off-time fluctuations. I do have GoCovery at my booth too, which is medication specifically for dyskinesia. But there, again, in the clinical trials, there was only 4% of dyskinesia reported compared to 4% with placebo. So basically, like very minimal.
I've got a follow-up question to the question the gentleman asked a couple of minutes ago. So, in your studies, how many people were able to wean themselves, percentage-wise,
Okay.
from the carbidopa-levodopa?
So patients, adjustments to the concomitant PD medications are needed during titration, seen around the 2 milligram per hour dose, which is about halfway to the optimal dosage. 33% of patients were able to continue one PD medication at 4 weeks, 15% mean reduction in levodopa dose at week 12. And then further reductions were seen in the open label extension. So that was during the 12 weeks, and then the further, if they were part of the open label extension, the numbers increased.
Last question.
What part of the brain or what part of the body is active?
So the drug that is used is apomorphine, which mimics dopamine. So it doesn't have to bypass the gut. It doesn't have to fight for protein competition. It goes straight into the blood-brain barrier to the postsynaptic receptors in the brain. So one of my doctors compares it to like going to the airport and having Clear instead of having to wait in the security line with the carbidopa-levodopa oral medication because you have to fight through so many barriers. This just goes straight to the brain.
No COMT. It's what we call a dopamine receptor agonist. So it's the same class as like ropinirole, pramipexole, those types of medications.
But the difference is apomorphine works on the D1 and D2 family, which differentiates it from other dopamine agonists because you don't see as many impulsive behaviors with apomorphine because it does work on the D1 and D2 family.
Okay. Last question. Go ahead.
I just want to know, because this is so new, are pharmacies in Rochester even aware of this, and do they give the ability to distribute these, or do they not go through the pharmacy?
So we have specialty pharmacy. So all you have to do is let your provider know that you're interested. They fill out the prescription form, which comes to us, and then we ship the medication directly to your home. So you don't have to go to the pharmacy.
All right. Thank you so much, Catherine.
Of course. Thank you all.
And thank you all so much for being here today. As Will said, I am Sandhya Seshadri. I'm a researcher here in the Neuropalliative Care Division of our Department of Neurology. And so just show of hands, how many of you know what neuropalliative care, it's a mouthful. Many of you already know what it is. So and you're way ahead of the game, because when I started working in neuropalliative with Dr. Benzie Kluger, who's our division chief, I was like, what am I doing in end-of-life care? Because we all thought that palliative was about end of life. And I'm here today to share with you the good news that our work and the work of neuropalliative care is really to work with people to live as well as they can for as long as they can. And while end of life is one part of it, and we'll all get there one step at a time, it's not about what is going to happen today. So without further ado, my goal today is to be able to talk about palliative care, hospice, and neuropalliative and supportive care, to try to understand some components of what we provide with regard to Parkinson's disease and Lewy body dementia, and also to talk to you a little bit about how palliative and hospice can improve quality of life. So, this is one of my all-time favorite quotations from Dr. Atul Gawande. Some of you may have heard of him. And I think it's so true, because we really fail to recognize that most people who are sick or are aged, they have priorities that go beyond being just safe and living longer. Everyone wants to be able to live a life that they would like to live. And so while we can't avoid suffering, we can choose to see how to cope with it, find meaning, and move forward. So a lot of our work is about how can we decrease suffering to the extent that it's possible, but also more importantly, what can we do to improve quality of life? So first question, since some of you already know, re-emphasizing palliative care is not the same as hospice. It's not about euthanasia or throwing grandma off the train. It's not about giving up on people. It's not about doing nothing. And it's not about only those who are dying next week. And it's not specifically only for people who have cancer. And it's also not only about palliative care specialists. As many of you may know, within the field of medicine, palliative care is a specialty by itself. And we have wonderful doctors who are trained just to provide that particular care. But within the neurology and other spheres, there is more and more doctors and clinicians who are providing care with a palliative approach. And that's what I'm here today to speak to you about. So, palliative care in our clinics complements what people get as a part of their standard care. So in chronic care, we focus on the disease, we focus on improving physical health, prolonging life, but in palliative care, we are focused on the total pain of serious illness. And I say the total pain because Dame Cicely Saunders, who, God bless her, was the wonderful woman who started this movement many, many years ago, she talked about total pain being not just the physical pain we all feel. It's the pain of what we may feel emotionally. It's the pain of what we may feel socially. It is everything else that gets encompassed into the psychosocial aspects of living and life. We focus on the overall well-being. We focus on people living with illness and for their families, and how their families can also live with illness. So illness is, we don't want to focus only on the disease. The disease aspects are important, but at the same time, we want to focus on how can we continue to live life well? So, palliative care is an approach for people who are affected by serious illness. And our aim is to improve quality of life and reduce suffering by addressing not just the medical symptoms, but the psychosocial issues, by addressing spiritual well-being, and by planning for the future. So, as I mentioned, Dame Cicely Saunders, I think it is just a historical accident. Her work started sometime, probably in the sphere of cancer, and we've all gotten used to associating palliative care with cancer and with terminal illnesses. But I love what she said. And she said, every single person, you matter because of who you are and because of the fact that you will matter to the last moment of your life. And that is what we aim to do in neuropalliative care. We want to see the person in there, and the person happens to have the disease. We work with the disease, but we're more interested in the human being. So what really matters, as many of you know here, for anyone who has a serious illness diagnosis, like Parkinson's or Lewy body dementia, what really ultimately matters to most people is their family. They want to be able to spend time with family. They want to have integrity and be treated with dignity and to be able to maintain their own dignity even though they may have a serious illness. They want to have some understanding of what does the future hold for me so I can start preparing from now. They want to be able to manage their symptoms. And I've heard this over and over again. They want joy. And they want to be able to figure out how to keep that joy. I was recently at a summit for people with dementia in Atlanta, which was run by a large group in black churches and congregations. And there was this amazing woman who came up to me and she said, I have Lewy body dementia. And every time I go into my clinic, my doctors talk to me about all the terrible things that are going to happen to me. I'm still alive. Can you talk to me about joy and what brings joy in my life? And that's what we try to do in our neuropalliative care spaces. There was another woman who got a diagnosis of dementia, and she said something so powerful to me. She said, my doctor told me, I'm sorry you have dementia. It's a terminal illness. And she said, I looked at him and I said, I don't know why you're sorry. I'm still here. And as far as I know, being born is terminal. So I just took that and I said, you go, girl. So in neuropalliative and supportive care, Steve Pantelot is a palliative care physician in California, and he described it beautifully. We're interested in it being about living as well as you can for as long as you can. And whatever that may take to help you live as long as you can and as well as you can, we're interested in the living well part of it, and we'll do everything we can to support that. So neuropalliative care is an approach that recognizes and addresses the unique palliative care needs of people living with neurologic diseases. And we try to understand the neurologic conditions and treatments, provide competence in palliative care approach. So we have support teams and communication across different members of our teams. And so then why for Parkinson's? That's a no-brainer. All of you in this room know that there are so many things that people with Parkinson's disease battle with that are sometimes under-recognized, and sometimes it's difficult. I had a patient yesterday tell me as part of my research work, she said, I didn't even know that was part of the symptom. A care partner said, my husband's really not interested in this, that, and the other that he used to be interested in before. I didn't know that apathy was part of the symptoms. So just being able to address the non-motor symptoms, and by non-motor we mean things like pain, fatigue, depression, and even sometimes grief. Grief is something that's very normal. Dr. Kluger, who leads our division, often says, you can have grief without depression. You can just feel sad and not feel good about the fact that you got a diagnosis like this. And that's normal and perfectly okay. And we should be able to provide support for that. And so the non-motor symptoms we feel plays a very important role. I had a care partner who told me once, can we please stop calling Parkinson's a movement disorder? It's the non-motor stuff that's driving us all crazy. I see some of you are nodding your heads on that. So there's demoralization and spiritual challenges. And when I say spirituality, I want to emphasize that in our clinics, we often have a chaplain work with people if they wish to work with a chaplain. And the chaplain, again, the word chaplain, just like the word palliative, seems to draw like, oops, I've had people say, oh gosh, no, I am good with my church. I don't need anyone to come and proselytize to me. And we often try to say that this is a member of our team. She or he is not here to talk about God. If you wish to talk about God, she or he will talk to you about God. But this is about answering questions which some of you may have had. I know I've had in my life when I've had difficulties to say, why the hell did this happen to me? I'm a decent human being. I do good things. This is not fair. So to answer that question or to even navigate that path of the unfairness of what is going on, that's what our chaplains do. And also to work with care partners. We are very interested in supporting care partners and listening to care partners. Parkinson's or any serious neurological illness, as you all know, is never the disease of just one person. It is a disease of the person and their family member. And it's often the care partners who go unrecognized, under-recognized. And as one care partner said to me, she said, I'm under-noticed in my clinics. I would love to feel like somebody more than just the chauffeur who brings my husband in and takes him back home. So that's what we are interested in. And yes, at the end of life, we also provide end of life and hospice. We refer to end of life and hospice or the specialist palliative care doctors when the time is right. And there is also high rates of complex bereavement after somebody passes. There may be some complex bereavement that happens, and neuropalliative can help with that too. So we're a response to the unmet palliative care needs of people with Parkinson's. Dr. Kluger and his colleagues did a big research study back in Colorado to see, does it even make a difference between the kind of care we provide and if we provided a palliative approach? And they found that, yes, it does. It helps both patients and it helps family members. So in Parkinson's specifically, when we work with people in the neuropalliative care clinic, when we talk about what are the 5 pillars that we're interested in, we're interested in being able to assess and manage not just the non-motor symptoms, but the symptoms, the needs of care partners. We're interested in addressing grief and spiritual needs. We're interested in making sure that there is at least an annual advanced care planning where you're thinking about, what would I like for my life? What are my wishes for the kind of care I want? And we also are interested in making sure that when the time comes, not today, but whenever it comes that somebody may need to go to hospice or to a palliative care specialist, that referral is made in a timely manner. So through the patient-centered outcomes research study, we did a 3-year study with the Parkinson's Foundation. You'll see some of that information out there in one of our tables at the neuropalliative care table that I have out there. And we're doing a lot to try to see how to bring this kind of care across the country. Luckily, in the University of Rochester, we do have a neuropalliative and supportive care clinic. So I've already mentioned the 5 things that we have. And in addition to that, we also provide anticipatory guidance. And I want to mention that a lot of times people talk about this new term called ambiguous loss. Care partners are often experience something called ambiguous loss. And so there are these types of issues also. If it is important and needed, we definitely have people within our teams who can address that. And so we strongly feel everyone deserves a palliative and supportive care approach. And this involves providing a diagnosis with skill and compassion. It involves addressing emotional and spiritual concerns, addressing non-motor symptoms, and supporting family members. And I think this is something that every one of us, regardless of what we may have, would want in our medical team. So shifting the focus from just the disease to the person and the family who happens to have the disease, but they are so much more than just the disease. So what I would say is, for each one of you out here, what you can do is become an activated patient and family member, get educated, come prepared to your visits, and ask questions. What's the worst that'll happen? Somebody will say, I don't know the answer. But if you don't ask, they can't give you the answer. So those are some of the things that you can do. If you want to know more about some of our research, please feel free to stop me, talk to me, or come to our table. We'd be happy to share that with you. And in our clinic, we seek to inspire through inherent kindness, wisdom, courage, joy, and love. And so as much as there is a lot of challenges associated with Parkinson's and Lewy body dementia, we are also interested in working with people to see what are the moments of joy that we can still have, and how can we nurture that and support you in having that. So with that, I say thank you, and I'm happy to answer any questions that you may have. Yes. So in our neuropalliative care clinic, the neuropalliative care is for anyone with a serious neurological illness. This event is about Parkinson's and Lewy body, so I was sharing information about Parkinson's and Lewy body. But definitely, yes, we do see patients across the board, depending on, I know in our clinic we have some people who have ALS, some people who have dementia. All of that is feasible, right? Yep. Okay. Oh, yes, yes. So Barb's question was, is neuropalliative care only for Parkinson's and Lewy body dementia? And she knows somebody who unfortunately has been diagnosed with Alzheimer's, so she wanted to know if that person would get care in our clinic, and the answer is an absolute yes. So any neurological illness, we would see people in our clinic. Yeah. So thank you. So Steve's question is, at what point in the trajectory of Parkinson's do you come to a neuropalliative care clinic? And is there any certain stage that happens? And the answer to that is, it depends on the person. We are not looking at it being only for people with advanced Parkinson's. Somebody may have something that they feel is very difficult for them. We've often had sometimes family members have some very complex situations and they need help from the neuropalliative care clinic. You can get a referral from your own neurologist. You can call in and get, so if you're within our system, of course, that becomes easy. When you meet your neurologist, you just say, I would like to meet with somebody in the neuropalliative care clinic. And you can come one time, you can come, depending on what services you need, you can get those services within our clinic. And we're all housed in the same place, so that should not be hard. If you're not within URMC also, you can still talk to your neurologist and see if you can get a referral, and that's entirely up to you. And you can self-refer also. We've had some people self-refer.
Another question over there.
I was just curious, is there such a thing as a checklist? I'm up to about 2 minutes late, so if you already showed that, I apologize. But there is a checklist of things that people can help prepare when it comes to all the things that, you know, I know neuropalliative care covers a lot of things, but is there maybe a list or a checklist that can start you in the right direction?
So that's a beautiful question. Sorry, I didn't get your name. Mike wants to know, is there a checklist that people can have ahead of time to prepare for something with neuropalliative care? And my simple answer is going to be no, we don't have a checklist. For Parkinson's specifically, we're looking at providing support for dealing with complex non-motor symptom issues. So oftentimes pain is something that people may come to our clinic. We may refer them on to a palliative care specialist if it need be for pain management. But we also have family members who's support for them, for grief and emotional support. So in terms of the 5 things that we provide definitely in our clinic, it is assessing and managing non-motor symptoms, assessing and managing grief and spiritual questions, assessing and managing care partner needs, talking about advanced care planning and what your future wishes are, and then referring in a timely manner to hospice and palliative care specialists when needed. But that being said, if you're seeking to come into the clinic, if you have a complex question, I would just say talk to your own doctors and your neurologists, and you can say that this is something I'm dealing with and I really would like a referral to neuropalliative care. And you can come in one time, you can still keep your neurologist, you don't have to shift to our clinic, and they will provide you with the support and answers. And since we're all connected, they will talk amongst each other. So I don't know if that answers your question. We don't have a checklist if that's your answer. Yeah.
So I guess as follow-up to that comment, as a movement disorder specialist, oftentimes when I suggest referral to neuropalliative, I'm met with the question of, well, what else are they going to offer? And can you provide some specific examples of how a neuropalliative visit might differ from a movement disorder visit?
I was hoping you could answer that. No, I'm kidding you. So Dr. Barbosa is one of our amazing neurologists, and certainly I know that it differs, again, personality-wise. Some doctors, when they, neurologists have very limited time. So they may, when you walk in, if you say, these are the key symptoms that I'm interested in addressing today, or these are my main concerns, they probably will ask you, what are the things that you would like to talk today in your visit? So you would talk, a lot of it might have to do with your specific motor symptoms, with how the medications are working for you, and if there's any titration that needs to be done in your medications when you meet. Is that right, Will? Is that what you...
That's correct. A lot of what we focus in oftentimes is what are the things that are most bothersome, and motor management of symptoms as being usually one of the main priorities. But as all of you probably know, Parkinson's is much more than just motor symptoms, and it can be multifaceted and have many symptoms that can be hard to really tackle in just one visit. So having our colleagues in neuropalliative as an additional layer of support can really be beneficial for certain people.
So yes, so thank you, and I think that's pretty much it. So when you go in there, you can, if there are other things that you would like to tap into, you definitely need, we have neurologists in our neuropalliative care clinic. We have a chaplain, 2 chaplains in our clinic. We have a social worker in our clinic. We'll be offering an array of services and referrals. Sometimes our neurologists in our clinic will also help coordinate and make sure you get the care that you need to. So they will talk to their colleagues and see how that can be managed. So think about it as an additional, as he said, an additional layer of support. And depending on what you need, we can address it. It's not that Dr. Barbosa can't address that. It's just that in his clinic, he's seeing so many different types of patients and he's seeing so many different symptoms. The focus tends to be on what is most bothersome today.
Any other questions?
Yes. Craig's question was, we talked about in our 5 pillars, talking about advanced care planning and what you would like for the future, plus referrals to hospice and palliative. So he says, what about planning for the next stage? And that's an excellent question. That is something that I think any of our neurologists, whether in the movement disorder clinic or in Neuropal, would be able to help you with. And that is part of what we call anticipatory guidance. So when you walk in, you can say, this is what I'm experiencing today. Can you tell me what I might experience in the next 1 year? So we are sensitive. I know Dr. Kluger, who is our division chief, often says it's not necessarily most helpful to a patient if we say every patient is different. Everybody with Parkinson's is different. If you've seen somebody with Parkinson's, you've seen one person with Parkinson's. To the person receiving that information, that may not be the most helpful thing. But at the same time, we are cognizant of that, and they will walk with you and talk about what are some of the things that are most concerning to you and how might it potentially look like in, say, 6 months to a year. And sometimes some patients and family members want to know that, and that's a legitimate question to raise with a doctor. But sometimes people are like, don't tell me. I'm terrified of what's going to happen, and they don't want to know. So we respect the array of how people would like information. Thank you.
If there are any other questions, there's a booth, right?
Yes, we are right there. My colleague, Dr. Corcoran, is also out there, and so stop by and talk to us.
Thank you.
Thank you.
I have the pleasure of introducing Gabe Geiger from Lifespan of Greater Rochester, here to talk about financial planning, management, and wellness.
Thank you, Dr. Wilt. Good afternoon. Can everybody hear me okay? All right, so I was told just now that it's a 15-minute presentation. I usually do this in about an hour. So first of all, lifespan. I think this first slide, age brings opportunity and challenges. So Lifespan is a resource in the community that provides information, guidance, and non-medical services to people in the second half of life. We offer about 30 different programs, and today I'm going to talk about one specific program called Financial Care Management. And I'm going to learn how to do this, right? There we go. So Financial Care Management is a terrific program. I'll tell you a little bit more about it. Wow, there's a lot of information there. Can you read what that says? It's a trustworthy wraparound financial care management. It's a reasonable cost that we've been providing for over 25 years. We've had different names for it, but essentially it's from simple bill paying to compiling tax information, overseeing bank accounts, insurance matters, investments. This service ensures financial well-being of an older adult. This is a fee-based service for older adults and caregivers who would like trustworthy assistance overseeing finances. Clients whose financial care management gives Lifespan a specific role to handle financial matters through a durable power of attorney. A power of attorney is a legal document that allows you to appoint a person or an organization to act on your behalf. We do not take the place of a client's lawyer, broker, financial planner, accountant, social worker, banker, realtor, whoever's there, we work with those people. to facilitate their respective responsibilities. Financial care management, I have to move this because I can't see what I'm supposed to talk about. Can I move this? So in financial care management, in order for us to be effective at what we do, is we need to get to know your financial information or your financial situation. In order to do that, we have to notify all of the third parties that you have had relationships with. That means utilities, banks, and other places, so that they know what our role is in facilitating assistance for you. We help you to obtain governmental and other benefits. For example, we've had people who've joined our program who are in their 70s who were not receiving Social Security benefits. So we help them to get their Social Security benefits because, as you know, at age 70, you kind of max out, so you should start collecting your Social Security. In this program, we handle all the mail that you get. Instead of you getting the mail, we get it. We keep track of all of your records for you. We pay your bills. We record the transactions. We reconcile your accounts, deposit checks. We compile your tax information and arrange them for tax preparation and filing. We don't actually prepare the taxes. We just compile the information for your CPA or accountant. You'll always know your financial affairs. This is our fee schedule for this program. We have a one-time enrollment fee of $250. So it's really a three-tiered structure. The enrollment fee is the one cost that's up front. What a lot of people do is they sign up for this program and they may not need our services right away. So if you don't need our services right away, the only thing that you're paying is the one-time enrollment fee. Once we're fully active with you, there's a monthly maintenance fee, and that covers the things that are at the bottom of the list, which is bill paying, deposits, record keeping, account reconciliation, dealing with the banks. We have a client investment committee that does reviews of your investments. We provide fraud and identity theft protection and an account audit on an annual basis. Really a very simple fee structure. If your assets are below $32,296, which is the Medicaid resource level, we charge $100 a month. If it's over that, it's $200 a month. So it's pretty affordable no matter what assets you're at. And again, we don't charge at a monthly rate until we're fully engaged in paying your bills. Beyond paying your bills, we can do other things for you as well. I call these concierge services. We can actually, oftentimes we have to create a realistic budget because people live on a budget for a long time, but it's not very realistic. So we take into consideration expenses that you may not have had in place before. We set up your accounts. We review your insurance policies. Insurance policies could be homeowner's insurance, car insurance, health insurance. Whatever kind of insurance you have, we will review, we will assess, we'll figure out if it's the best policy for you. You know, oftentimes when people choose their health insurance, during open enrollment, they'll do it once and then they think they're done. But you really need to review that on an annual basis because the policies do change. If there are creditor issues, we'll take care of negotiating those issues. Again, talked about tax compilation. We do home monitoring. So if you happen to move out of your home, maybe for rehab, we will continue to monitor your home. We'll visit your home on a regular basis. If you decide that you need to move from your home and you need to move to assisted living or skilled nursing, we will work on selling your house, the contents of the house. If you need to sell the car, we will do that as well. You know, oftentimes when you move from a 3-bedroom apartment and you're moving into assisted living, which is a 1-bedroom apartment, very difficult to get all that furniture into that 1 bedroom, right? So we'll work on consolidating that and figuring out what we need to do with that property. We may need to send some of that property to your niece in Oklahoma. We can do that. So we can identify appropriate housing for you. We'll do the housing move, the transition, the storage. I am not going to go and move your sofa, okay? We're going to hire somebody to do that. If you require annual house recertification, we'll do that. We'll work on simple Medicaid applications. If people have complex Medicaid applications, those really have to be done by an attorney. We'll work with the estate because, as you know, a power of attorney is good while you are alive. After you pass, your will determine how your assets are distributed, and we will work with your executor. We'll also make sure that you have funeral arrangements. If you don't have funeral arrangements, we'll get them in place. If you do have funeral arrangements, we usually get the first call after a person passes as far as what the arrangements are. So if you're planning and you haven't done your funeral arrangements, take care of those, but if you can't, we'll do that for you as well. We'll work with the executor and the administrator. Our fiscal responsibility to our clients is to keep clients financially independent as long as possible, work with the client team to create security, deliver for individual needs. So this is, I can't see this from here. Just bear with me a second. I like this slide because it gives you an idea as to the clients that we serve. And just bear with me a minute. So the clients that we serve, you know, the majority of our clients are between 70 and 90, but they can be anywhere from around 60 to a little bit over 100. You can tell the percentage of clients that we have on that chart. Overall, average age of the client is 79. Most clients are female. Let's see, what else does that slide tell you? Suspected financial exploitation. Generally speaking, once we take over, we do identify in about 26% of the cases there is some form of financial exploitation. So we address that. We work with law enforcement to try to get the funds back. But one of the reasons to have our service in place is because it will keep you safe and secure. 44% of our clients are unmarried. 16% are widowed. No, 32% are widowed, I think. Yep, 32% are widowed. So we serve clients from across the board. The clients we serve, the next slide. This gives you an idea as to the asset range of our clients. I guess about 37% of our clients have assets under $50,000, but we serve clients that have a couple $1 million and anywhere in between. So people have come to rely upon us to provide these services. Let's see. So again, some solutions. We educate on the importance of having an estate plan, making sure that everybody has the power of attorney, healthcare proxy, the will, and funeral arrangements. We never want to see a client pass away without funeral arrangements. It is a mess. So we make sure that all of our clients have the funeral arrangements. There's always new tools and new ways of thinking and optimizing processes. The client impact that we have, I'll share with you some of the things we have done. Obviously, we've done a lot of house sales, car sales, client moves. We've submitted 21 financial aid applications. This was last year, or recertifications to area hospital systems, resulting in multiple awards of 100% coverage. We've requested and were awarded no rent increase for low client assets. We won health insurance appeals. There was one client that moved to another state. Health insurance did not cover $18,000 worth of expenses. We got that covered for the client. So we make significant, we help clients significantly. I know my time is almost up. Thank you, Dr. Will. So we've applied and we were awarded widow's benefits, just a lot of different things that we do. We have found money for people. It's not on the slide here, but I remember a couple of years ago we found $84,000 for one client in one account in one bank. So we've done a great job in finding money for people. We submitted Medicaid applications. We review your investments to make sure that your investments are properly aligned so that you don't take too many risks. We open lots of certificates of deposits, making sure that you have safety in your investments. These are many of the people that refer clients to us. Lots of people in the community do that. If you do have questions, this is my contact information. Feel free to reach out to me. You can just call us at Lifespan 244-8400 or contact me directly. I'm happy to answer any questions that you might have at this time.
Any questions from the audience?
I'm happy to stick around to answer questions after the presentations as well. Sorry.
No, I would just add a comment. Oftentimes when people are dealing with chronic illnesses, financial planning tends to get thought of sort of as a second thought, because symptoms take priority oftentimes, but there is definitely an importance to financial planning early on. And I appreciate you being here today to talk about
Thank you.
the services that Lifespan has to offer. Is this the easiest way to get a hold of you?
Yes.
Okay.
Yep.
So certainly if anyone is interested in setting up an appointment to talk further, I guess you'll also be here for a moment afterwards as well.
Yep.
Very much encourage you to reach out if you have any questions.
Thank you, everybody.